Bismillahirrahmanirrahim. Today, on the behalf of my Indus team, Indus has organized a conference, biennial conference, the ICON conference. It's my pleasure to welcome you all on the behalf of the hematology team of the Indus Hospital also in this conference. Today, in this session, we deal the emerging hematology, and the theme of the today's is the emerging hematology and insight into the future. It's a very interesting session, and in this session we cover all aspects of the hematology and flows, routine hematology topics, coagulations, flow cytometry, and the cytogenetics, and then the little we will discuss some interesting and some difficult and the challenging cases at the last. uh, Before initiating the talks, the first talk is of the Dr. Fatima Meraj. She is the section head of the hematology and the blood center in the Indus Hospital, and she is a very uh, 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 hard worker and uh, head and she has a very great efforts in the Ziauddin Hospital and the Indus Hospital too for the developing of the systems and the flow cytometry and the specialized test in the hematology department of the Indus Hospital. I would like welcome to the Dr. Fatma Meraj, and she will give a little talk on the flow cytometry. And her topic will be for the recent innovative immunophenotypic modulation in the pediatric B cell lymphoblastic leukemia. I welcome to the Dr. Fatma Meraj for this new and the initiative topic on the flow cytometry.
Assalamu alaikum. I'm Dr. Fatma Meraj, Section Head Hematology and Blood Center at Indus Hospital and Health Network. Today I'm going to talk about antigen modulation post chemotherapy through flow cytometric assessment. This is basically a study which is done on B cell acute lymphoblastic leukemia patients. As most of us know that flow cytometric analysis of acute leukemia is a very rapid method of diagnosis of acute leukemia patients. And in addition to the diagnosis, it also gives the prognostic markers which can be used in the treatment management. It is particularly important to be able to differentiate hematogones from the neoplastic B cell precursors in the diagnosis and monitoring of BLLs. Basically, not in the initial diagnostic marrow, but rather in the minimal residual disease analysis, the major challenge is hematogones. So because the B cell lineage, lymphoblast and hematogones, they often share immunophenotypic characteristics. They sometimes can be mistakenly diagnosed as lymphoblasts rather than being labeled as hematogones. So what is the reason of this confusion? It is basically to basically differentiate between the hematogones and lymphoblasts, we have to understand the normal immunophenotypic pattern of the hematogones and how these can be altered in lymphoblast. And this is the way we can differentiate between the hematogone hyperplasia and BLL, which is very critically important because at the diagnosis and during post-therapy monitoring of minimal residual disease. The hematogone population, they demonstrate a characteristic and highly reproducible pattern of maturation, whereas the lymphoblasts, they show aberrant expression of at least one or more of these markers, which are normally expressed in hematogone in a specific pattern. In the next two slides, I will discuss about this maturation pattern. Like in hematogones, as it is, there's a list of markers and there is a dot plot, which you can see in this slide. The blue ones are the mature B cells and the cyan ones are the hematogones. And hematogones are basically the maturing B cells. So the maturing B cells means that initially they will carry immature markers, and as they mature, they will lose the immature marker and gain the markers of maturity. So the earliest hematogones, they are positive for CD34 and you can see here, they are positive for CD34 and 9, and but they are negative for CD20. And as the cells mature, they start acquiring CD20 and they start losing CD10. And in the meanwhile, they start losing the CD34, which is marker of immaturity, and they start also losing CD9s. Along with this, CD38, they are also, like, initially they are very bright and then they start getting dimmer. And so is the case with CD45. They are initially dim and then they start being highly, strongly antigenically expressed. So this is a specific pattern of hematogones. But what happens in lymphoblast, uh, there is aberrancy in these specific pattern. In this diagram, you can see, in addition to the cyan, which is a hematogone, and the blue population, which is a mature B lymphocyte, there's one red population, which are called the blast, the lymphoblasts. These are basically the malignant cells. So the difference between the hematogones, they are maturing cells, like they would mature in time after certain time, while the lymphoblasts, they have a maturation arrest and they will not mature further. So the aberrancy or the abnormal markers which can be seen in these blasts are, like, there's a very intense and uniform expression of immature markers in CD9. They will, all the populations will express the markers uniformly, and they won't have a pattern to lose it. Like in this 1020 dot plot, you can see that hematogones, they are, one thing they are acquiring and the other thing they are losing, while in the malignant blast, all of the markers have the same pattern of presentation. And same is the case that there is immunophenotypic asynchrony, meaning there's co-expression of early markers and the late markers. In this scenario, the early marker is CD34 and 9, and the late marker is CD20. And so that's why this can be diagnosed as this can be diagnosed as lymphoblast rather than hematogones, because the maturity marker and immaturity marker both are co-expressing in the same population. And the third is, there is over or under expression of the markers. Like in CD38, normally the lymphoblast, they have variable expression and there's bright expression of CD58, while hematogones are either negative or they are dimly expressed. And then is CD45. CD45 is usually dim and they don't have any spectrum of getting mature with time. So they stay dim, while hematogones, they initially are dim and then they start acquiring the 45 antigen very brightly. So something about minimal residual disease. Disease monitoring in management of acute leukemia is very important for risk stratification and assessing the response to chemotherapy throughout the disease course. And there are multiple parameters which can be used for risk stratification of the disease. And one of them is minimal residual disease, MRD, and it is a very reliable assessment tool so that the treatment options can be managed accordingly. Flow cytometry is one of the modality which can be used to assess the MRD, and flow has like a very good sensitivity. It's like you can identify one residual blast out of 10,000 nucleated cell or one residual blast out of 100,000 nucleated cell. So it has a very good reproducibility and it's most widely used modality. And the principle of measurement by flow cytometry is the same, like it is basically based on studying the difference between antigenic expression of leukemic cells, hematogones, which is again the maturing B cell precursors, and the residual normal B cells within the same sample. So the cells of ALL, which is acute lymphoblastic leukemia, they differ from normal lymphoid precursor mostly by quantitative aberrations or differentiation associated marker, or there are certain antigens which are not present in the maturing cells, meaning hematogones or mature cells, and they are only present in the lymphoblast. So it's a combination of assessing the maturation pattern and also the combination of identifying unique aberrant marker which cannot be identified in either hematogones or mature B cells. So the use of flow cytometry to monitor MRD in patients with BALL assumes that leukemic cell retain the immunophenotypic aberrancy throughout the course of the therapy, which was identified at the time of the diagnosis. But contrary to this is there are modulations in antigen expression do occur in the leukemic blast during the treatment. And these modulation can cause the difficulty in analysis and detection of the minimal residual disease, because these markers are not very stable and they tend to change their expression because of the therapy. So this turns into a diagnostic dilemma actually. During the chemotherapy, there are shifts in antigenic expression, and they frequently occur during the initial stages of the treatment, especially during the glucocorticoid phase of the induction therapy. So, such phenotypic shifts they pose a great challenge since they can cause misinterpretation and may lead to false results. So applying multiple marker combination is considered one of the appropriate strategy. Like you increase your panel of markers through which you can identify either specific markers which are not present in the maturing cell, along with the pattern of maturation which you know how it has to be in the hematogones. So this would be helpful in differentiating between the two scenarios. To date, the biological mechanism underlying this antigenic shift has not yet been fully investigated. So, but still there are certain hypotheses, and one of them is drug-induced antigen modulation or due to leukemic subclone selection resulting in variation in the antigenic profiles. So what is drug-induced modulation? It is basically related to drug-induced cell death, and this results in loss of membrane antigens or higher non-specific staining. And leukemic, and what is leukemic subclone selection? There are basically a small subclone which may be present in the leukemic cell even at the time of the diagnosis, but they were so small that they were not identified at that time. So sometimes this can happen that this small subclone, they may resist the chemotherapy phase better than the bulk of the leukemic cell, so they may flourish and they may be identifiable at the time of the MRD assessment. So this phenomena usually affects all the markers which are used as a backbone markers in the leukemia typing. For example, like CD10, CD19, 20, 34, CD45, TDT. These all markers are also present in hematogones, and they are also a backbone of leukemia phenotype. So this creates confusion. For this, we should have a clear picture of the maturation spectrum. So the question arises, the stability of these leukemia-associated immunophenotype. What is the stability of these phenotypes? This is one of our major question, because this through this answering this question may lead to some clues in the diagnosis of MRD. So to observe this antigenic shift, we conducted a single center study at our institution to observe the trends of the immunophenotypic modulation in our pediatric population of leukemic blast. And this was studied at the time of the diagnosis, followed by different phases of chemotherapy. And this antigenic expression was observed not only in the leukemic blast, but also in the non-leukemic B cells, which were present within the same sample. So actually what we intend to study was to study the influence of the drugs on the leukemic cells as well as on the non-leukemic cells, meaning the benign B cells. So the 203 MRD positive patients, pediatric, these were basically pediatric patients of 1 to 18 years were recruited in the study of flow cytometric MRD assessment. Peripheral blood and bone marrow samples were received at the diagnosis, and then throughout the follow-up during day 33, 52, and day 78 of the treatment. And they have received a BFM protocol with 7 days prophase initially given. Cell acquisition was performed by 8-color flow cytometry, BDFX Canto, and data analysis was done by DIVA software. And these are the list of the antibodies which were used in the diagnostic as well as in the MRD samples. So the MRD results were collected and compared from the time of diagnosis, which is labeled as day 0, followed by day 35, which is post-induction phase of the chemotherapy, it's end of the post-induction phase of chemotherapy. Then at post-consolidation phase, which is day 52, and during the maintenance phase at day 78. So antigenic expressions were quantified on the basis of mean fluorescence intensity uh, at the diagnosis and throughout the treatment phases for both the blast cells and benign B lymphocytes within the same specimen. Our results showed that among 203 cases, 61% were males and almost 40% were females. The median age were 5 years with the interquartile range of 3 to 8 years. Expression of these 9 antigens were studied in BLL patients in the diagnostic as well as in the MRD, and CD45, 19, and 20. Only these 3 antigens were studied in the benign B cell mature population. These are basically the mature B cells. Because the mature B cells, they won't express TDT 34, 16, 66, 13, or 33. So only these 3 markers, which is the marker of benign B cell, were studied in this group. Now I'm going to share some of the results. This is a graphic representation of box through box and whisker dot plot. In this, you can see a box which basically represents the interquartile interval, which is the middle 50% of the data, while the whiskers, they are explaining the spread of the data. So the lower part of this whisker is representing 25% of the data, lower 25%, and the other part, upper part, is representing the upper 25% of the data, and this is the 50% of middle 50% of the data. The orange and the red, basically the junction between the orange and the red is representing the median of this data group, and the lines connecting, they are basically representing the variation throughout the phases for each antigens. So as you can see, these are our patients' MRD results. So as you can see in CD45, there is a slight down regulation of the antigen marker. This is basically the day of diagnosis, diagnostic results. This is day 35, meaning post-induction. This is post-consolidation, day 52. And finally, this is basically pre-maintenance, during the maintenance phase of the therapy. So there's a slight down regulation of CD45. Same is the case with CD19. Initially, they are very stable, and then there is slight down regulation of CD19 as well. Then here you can see CD10, which is very important marker, and you can see that between the diagnostic flow cytometry and in post-induction, there's a significant decline, meaning there's significant down modulation of CD10 antigen expression, and this is followed by up modulation. And finally, at pre-maintenance phase, they are approximately similar, they have approximately similar expression to the diagnostic. So there's variation in CD10 expression throughout the treatment phase. In CD20, sorry for, please ignore the upper and the lower lines. Just we need to focus on the middle one. So CD20 is also quite a stable marker with slight upregulation in the day 35 phase. And but overall, it's quite a stable marker throughout the therapy phase. Then TDT. TDT and CD34, both are markers of immaturity. So they can both, especially TDT, they have a very significant rise compared to their diagnostic expression. And you can see there is a rise in day 35, but there is quite significant rise in post-consolidation and then pre-maintenance phase. And CD34, there is a very reversible pattern. Initially, it goes up, then it goes down, and then it goes up. So it has a very reversible pattern of expression throughout the course of the therapy. Finally, I'll talk about CD66 in lymphoblast, MRD positive cases. CD66, When expressed at the time of the diagnosis, they are usually stable till day 35, meaning post-induction MRD, meaning we can identify them through flow cytometry, but in post-consolidation and pre-maintenance, they are usually down-regulated. So initial till PI, post-induction, they are very stable, but then they lose their antigenic expression. This is a dot plot representation, how we look through the analyzer. This I'm only showing CD10 and CD20, these two markers. Like in CD10, you can see this is basically a log scale. So the most of the malignant population, they are present between 10 raised to power 3 and 10 raised to power 4. But as the treatment goes, especially at post-induction, they have been down-regulated, as I have shown in the box and whisker. The red population, you can see it's being down regulated, and then in the post consolidation it has gained the marker again, and finally in pre-maintenance phase they are approximately of the same expression as at the time of the diagnosis. In the next two slides, I guess, I'm going to talk about the antigenic expression and variation in the benign B cell population. So the modulation of the antigen in benign B cell population, and this would be like again in the same pattern at the time of the diagnosis, where the benign B cells which were present along with the malignant cells, and then through post-induction, then through post-consolidation and pre-maintenance. So you can see that CD19 is initially stable till post-induction, and then it has declined in post-consolidation and pre-maintenance. Same is the case with 20. It is also quite stable with a dip in post-consolidation phase. And finally, the last marker which we studied in benign B is CD45. And you can see there is a steady decline of antigenic expression throughout the phase of the chemotherapy. So what we have gathered the information is, even throughout the chemotherapy, even not only the malignant cells were affected, but the benign B cell population, they were also down regulated at various stages of the chemotherapy. So in conclusion, I want to conclude that the what we observed, that the changes have occurred both in the benign cells as well as in the malignant cell. And in the malignant cell, our conclusion were CD45 and 19 are quite stable markers with slight variation. CD20 showed initial upregulation followed by a stable pattern. And there's significant upmodulation of TDT, and CD34 has very reversible pattern of expression throughout the phase of the treatment. And other aberrant markers like CD66, CD13, and 33, which are basically myeloid markers, but they are aberrantly expressed in lymphoblasts. They are usually stable till post-induction, but there is quite significant downregulation after the post-induction phase. So I would like to conclude, according to our data, that there is indirect evidence of drug-induced modulation of antigen expression during various treatment phases of the acute lymphoblastic leukemia. Hence, careful application of multiparametric flow cytometry is necessary to warrant correct and reliable MRD results in leukemia follow-up, because our analysis will direct the patient's further management plans. So this must not include only usage of multiple markers to exclude the false results due to phenotypic changes, but it should also include the knowledge on the typical phenotypic patterns of the antigenic expression in normal cells as well as in the leukemic cells throughout the phase of the chemotherapy. Okay, thank you.
Thank you, Dr. Fatma Meraj. A very informative talk on the flow cytometry and the antigen modulations. And in this talk, you gave a very detailing about the how the antigen becomes modulate and the down regulating and the low role of the MRD in the management point of view of the treatment, especially in the BLL. Uh, Really, Dr. Fatma has very great role in the development of the flow cytometry and especially the MRD in the Indus Hospital. And she always trained the every hematologist and their trainees for this. And she has a very she is a very smart in this technique, I say. Thank you. She also trained me and the both of hematologists in this. Thank you, Dr. Fatma Meraj. Thank you so much. Now, the second talk is the external speaker, Dr. Munira Bharani. She's a very famous consultant hematologist, and she is attached to the National Institute of the Blood Diseases, NIBD, the very famous one. Her role, she is now the professor of the hematology and the consultant hematologist, and currently she is also a medical director of the NIPT. Uh, uh, in her services, she initiate many things and the treating the patients, and her role in the coagulation is also a very acknowledgeable. So today's the topic of the presentation of her is the diagnostic approach to bleeding disorder. So I welcome Dr. Munira to please come and start her talk. Thank you.
Bismillahirrahmanirrahim. My name is Dr. Munira Bharani, and I am working as a consultant hematologist and medical director at National Institute of Blood Disease and Bone Marrow Transplantation Center, Karachi, Pakistan. It's my great honor and pleasure to be a part of ICON 2022. And the topic assigned to me is diagnostic approach to bleeding disorders. I have nothing to disclose. The agenda of today's presentation is I will give you an overall background of bleeding disorders, what are inherited bleeding disorders, what are its prevalence, how to diagnose these bleeding disorders, and what is the importance of the bleeding history, what is the relationship with the severity of the bleeding to the clotting factor levels, the interpretation of screening test, how do we diagnose the von Willebrand disease, the platelet aggregation test, and how to tailor the workup for the bleeding disorders, and ultimately the take home message from this presentation. So the background, the what is background of this bleeding disorders? We all know about this, the clotting cascade, and this clotting cascade starts with the injury of the blood vessels. When there is an injury in anywhere in our body, the broken blood vessels, the endothelium gets exposed, and when the endothelium is exposed, the platelets and the red blood cells start the function, and the primary hemostasis comes into an action. And when this comes into an action, the clotting cascade gets activated and the secondary hemostasis is activated. And you can see the first, the tissue factor is activated, which releases factor 7, and this factor 7 releases other coagulation factors. This works in a like a chain of events. These coagulation factors are activated. First the extrinsic pathway is activated, which is followed by the intrinsic pathway, and then the common pathway, and finally there is a clot formation in the blood vessels to stop the bleeding. So, what are the inherited bleeding disorders? Keeping in mind this, the coagulation cascade inherited bleeding disorders are a heterogeneous group of bleeding disorders, which may be due to the genes involved in the coagulation factor deficiency, in the megakaryopoiesis, or in their function. So the most common are hemophilia A or B, the von Willebrand disease, the rare bleeding disorders, and inherited platelet disorders. What is the prevalence of these bleeding disorders? The World Federation of Hemophilia, the recent annual global surveys indicate that the expected number of males with hemophilia worldwide is about more than 1 million, and majority of them are undiagnosed and are present in the underdeveloped countries like Pakistan and other developing countries. And you can see that in hemophilia A, the prevalence is around 24 per 100,000, most common bleeding disorder, followed by hemophilia B, which is 5 cases per 100,000. For von Willebrand disease, you can see the different prevalence depending on the type of the von Willebrand disease. For the platelet disorders, it's also less, 1 in 1 million. For the rare bleeding disorders, which are more common in countries where there is a high frequency of consensuous marriages, like in Pakistan, usually the RBDs represents 3 to 5% of all inherited coagulation factor deficiencies, and they are transmitted as autosomal recessive traits. But in Pakistan, we see very commonly the rare bleeding disorders because of the family marriages. This figure shows the WFH annual global survey of all bleeding disorders. And you can see this is the world population line, which is increasing day by day. And you can see from here that the number of patients with bleeding disorders are gradually increasing. This might be because we have improved our diagnostic services, so the bleeding disorders are getting more diagnosed as compared previously. Similarly, for the rare bleeding disorders, you can also see the numbers has gradually increased with time, and there is a high frequency of rare bleeding disorders in countries where there is a common practice of family marriages, like in Pakistan. The clinical diagnosis, very important point. How do we diagnose the patients with a bleeding disorder? If the bleeding disorder is suspected, the clinician always obtains a very good bleeding history, the family history of abnormal and unexplained bleeding experiences from her family or his family members, especially in male patients, their autosomal X-linked disorders. You take a good history from the mothers as well, because the children usually don't tell us about themselves. So parents and their families are very important tool for taking a good history. The patients should understand what are the bleeding disorders and why do you need to tell the patient and counsel them about the hemostasis workup, because if the patient is not diagnosed properly, you can't treat them properly, because the diagnosis is key for the proper management. So we can say that the best screening test for a bleeding disorder patient is a good bleeding history. The bleeding history includes what points should be included. Number one, the age of onset of the bleeding history. Usually in the inherited bleeding disorders patients, we get a bleeding history in the parents, in the families, in the close family members, because they give all. But sometimes it is like in mild bleeding disorders, the parents and the families are not aware of any bleeding history. So age is very important, especially for the inherited bleeding disorders. Similarly, the pattern of bleeding, which type of bleeding does the patient have, whether it is a mucocutaneous type of bleeding or deep tissue bleed. Similarly, the time of onset after the hemostatic challenges is very important, whether the bleeding has occurred spontaneously or after minor or major hemostatic challenges. This is the ISTH bad bleeding score, and we usually use them at baseline. We usually, when taking a history about the bleeding symptoms, we take a scoring, we use a scoring system, and we give them a scoring point. And we see that if the scoring is significant, then we go for the screening test. So, I mean to say that a diagnostic approach should be very logical, and standardized approach is needed, especially for the screening of these patients. And you have to ask them specific questions about when the bleeding started, what is the type of the bleeding, is it spontaneous bleeding or after some trauma or some injury, or is there a positive family history of bleeding present, or there's a bleeding in the siblings. So a comprehensive bleeding history is very important, which helps us in the pre-test probability that a patient has a bleeding disorder or not. Then we go for a global screening test. And what are the global screening tests which the bleeding disorder patients need? The different bleeding disorders may have a very similar symptoms. So on the basis of the symptoms, we cannot differentiate which type of bleeding disorder is. To make a proper and the correct diagnosis, we need proper test, and the test depends on the knowledge and the expertise of the coagulation laboratory testing. You have to use the correct equipments, correct reagents, and make a proper quality control, so you have a assurance that the what the laboratory is giving the test is our optimum, are okay, and matches with the bleeding history and the bleeding type of the patient. What are the principles of diagnosis? The diagnosis of bleeding disorder is based on the following three principles: understanding the clinical features of bleeding and the appropriateness of the bleeding diagnosis, and then the use of proper screening tests, like we use prothrombin time, activated partial thromboplastin time, platelet count, and the thrombin time. These are the screening tests which we prescribe to the bleeding disorder patients after taking proper medical and history, complete history, then taking a ISTH bad score. We go for the screening test. Test to then we go test to identify the potential cause of bleeding and to exclude the other diseases. So the possibility of the clinically relevant bleeding history being present and confirmed by the specific factor S is very important for the specific diagnosis. This is the algorithm which we used in our daily practice. You see in this algorithm which I follow in my practice, that we give a very good weightage to the clinical history of the bleeding disorder patients. After getting the history, I go for the screening studies. So these are the basic screening studies which we are used to use for these bleeding disorder patients, like CBC, review the blood film. We go for the basic screening test, bleeding time. These are the basic screening tests which are done in all bleeding disorder patients. If the PTAPTT are abnormal, so it means there is some coagulation factor deficiency, especially in the common pathway. Then we follow that either there is APTT only prolonged or PT prolonged. If only PT is prolonged, then we go for the factor 7, means extrinsic pathway defect. If the APTT is prolonged, we go for factor 8, factor 9, and factor 11. Sometimes, if we may get a mixing study done to identify whether there is factor deficiency or some type of anticoagulant present, like lupus anticoagulant. But usually, in the bleeding disorder patients, the lupus anticoagulant screen is negative. If we get an abnormal CBC with the blood film and prolonged bleeding time, So we always screen for the von Willebrand disease, and we go for the specific test to identify the types of VWD, whether it's type 1, type 2, or type 3. But the further subcategory of the type 2 is not possible because the multimer analysis is not present in Pakistan. So only we perform the von Willebrand factor antigen, the Rykov, and the factor 8 for the diagnosis of the von Willebrand disease. For the diagnosis of platelet disorders, we go for the platelet count, for the morphology, and then for the platelet function test to evaluate the platelet functional disorders. If these tests are all normal and there is no abnormality, then we go for the factor 13 assay. As I said previously, that in our country where the family marriages are very common, we see lot of rare bleeding disorder patients in my practice. So, what is the relationship of bleeding severity to clotting factor levels? जितना ज्यादा क्लॉटिंग फैक्टर कम होगा इतनी ज्यादा ब्लीडिंग की सिवियरिटी एंड द ब्लीडिंग एपिसोड्स आर मोर अगर फैक्टर लेवल इज लेस देन 1% so there is all usually a spontaneous bleeding into joints, into muscles, or any where in the body. If the factor level is between 1 to 5, we say it's a moderate deficiency. So occasionally the spontaneous bleeding ho sakti hai, prolonged bleeding after minor trauma and surgeries. Usually the mild bleeding disorders do not come to the hospital because उनका factor level इतना होता है कि उनकी spontaneous bleeding नहीं होती. They usually get the bleeding symptoms after like some major trauma हो गया, surgery हो गई. Usually they have very rarely spontaneous bleeding. So usually we get the severe and the moderate ones in our practice. This are the flow this diagram usually shows this diagram shows the interpretation of the screening test. अगर हमारे पास ये screening test आप देखें कि पीटी भी नॉर्मल है, एपीटीटी भी नॉर्मल है, ब्लीडिंग टाइम भी नॉर्मल है, प्लेटलेट काउंट्स भी नॉर्मल है, एवरीथिंग इज नॉर्मल, तो यूजुअली द ब्लीडिंग डिसऑर्डर इज अनलाइकली एक्सेप्ट फैक्टर 13, और या फिर प्लेटलेट फंक्शनल डिसऑर्डर हो सकते हैं जिसमें ये पॉसिबिलिटी है. अच्छा, हीमोफीलिया अगर ए और बी है तो यूजुअली एपीटीटी इज प्रोलॉन्ग. फॉर वॉन विलिब्रिन डिजीज सेम, द एपीटीटी इज प्रोलॉन्ग बट मे बी नॉर्मल इन द माइल्ड डिसऑर्डर्स. द प्लेटलेट काउंट आल्सो मे बी नॉर्मल टू रिड्यूस्ड. सिमिलरली अगर प्लेटलेट फंक्शनल डिफेक्ट है तो वहां पे भी ब्लीडिंग टाइम प्रोलॉन्ग होगा और प्लेटलेट काउंट में बी नॉर्मल टू रिड्यूस्ड. For the von Willebrand disease, we usually test. हम कौन से टेस्ट करते हैं for the diagnosis of the von Willebrand? As I told you previously, that in Pakistan we usually diagnose von Willebrand disease based on the factor 8 activity assay, von Willebrand factor antigen, and the Rykov resuscitant cofactor. ये basically function of von Willebrand बता रहा होता है. Is indicated in most patients, especially presenting with the mucocutaneous bleeding symptoms. इसके अलावा हीमोफीलिया ए में भी जब भी हम डायग्नोज करते हैं फैक्टर 8 की डेफिशिएंसी में, हम ये वॉन विलिब्रेंट फैक्टर एंटीजन जरूर करवाते हैं फॉर द डायग्नोसिस ऑफ द वॉन विलिब्रेंट डिजीज, बिकॉज समटाइम्स देयर इज एन ओवरलैपिंग ऑफ सिम्टम्स एंड यू कैन नॉट एग्जैक्टली से कि हीमोफीलिया है या वॉन विलिब्रेंट डिजीज है. देयरफॉर इट्स वेरी नेसेसरी कि जब भी फैक्टर 8 की कमी हो या डेफिशिएंसी हो, you always check von Willebrand factor antigen to rule out von Willebrand disease. For platelet aggregation test, which is the platelet aggregation test is done for the diagnosis of the platelet functional defect. अब platelet functional defect हमारे यहाँ जो most common है वो है Glanzmann's thrombasthenia and the Bernard Solier. Other bleeding disorders में और भी platelet disorders मौजूद है, लेकिन चूंकि हमारे पास only aggregometer is available in Pakistan using ADP, epinephrine, arachidonic acid, collagen, and ristocetin. So we usually diagnose platelet functional disorders. उसकी भी लेकिन लिमिटेशंस हैं कि उसको किस तरह करना चाहिए, और उसके अंदर पेशेंट की प्रिपरेशन इज वेरी इंपॉर्टेंट. वेन एवर वी स्टार्ट द प्लेटलेट फंक्शनल स्टडीज, वी आस्क द पेशेंट नॉट टू टेक एनी ड्रग्स, स्पेशली वो जो खून पतला करने वाली दवाइयां होती है वो नहीं देनी होती है हमें. कुछ इंग्रेडिएंट्स है खाने पीने में जो जिससे अवॉइड किया जाता है ताकि प्लेटलेट फंक्शनल डिसऑर्डर्स की जो डायग्नोसिस है वो अप्रोप्रिएटली हो. बट सम एग्रीगोमीटर से हमारी लिमिटेशंस ये है कि स्टोरेज डिफेक्ट्स आर नॉट एबल टू डायग्नोज, सच एज द डेल्टा स्टोरेज पूल डेफिशिएंसी which we cannot diagnose with the help of the standard platelet aggregometer. For the delta deficiency we need the electron microscopy. लेकिन electron microscopy is not available in Pakistan, but it's क्योंकि हमारे पास available नहीं है, therefore there is limitation in the diagnosis of the dense granules की जो deficiency होती है, we are unable to diagnose them in Pakistan. कहने का मकसद ये है कि जब भी आप ब्लीडिंग डिसऑर्डर्स की डायग्नोसिस के लिए स्टार्ट करते, यू हैव टू टेलर योर वर्कअप बेस्ड ऑन ऑल दीज थिंग्स, यानी गुड हिस्ट्री, फिर आप उसकी स्क्रीनिंग टेस्ट के से पहले आप उसका ISTH बैड ब्लीडिंग स्कोर फिल करते हैं बेस लाइन पे, देन यू गो फॉर द स्क्रीनिंग टेस्ट, एंड आफ्टर द स्क्रीनिंग टेस्ट you make a specific factor assays to properly diagnose the bleeding disorders. और जैसे मैंने आपसे कहा कि inherited bleeding disorders are usually diagnosed earlier in life, especially अगर इनकी severity बहुत ज्यादा है, तो severe and the moderate ones usually present earlier in life. लेकिन कुछ प्रॉब्लम्स हमें आते हैं और इवैल्यूएशन उनकी उस वक्त प्रॉब्लमेटिक हो जाती है जब हॉस्पिटलाइज पेशेंट्स की बात होती है, और जब हमें रेफरल्स मिलते हैं फॉर द फर्स्ट सर्जिकल ब्लीडिंग, वहां बहुत सारे हमें कॉम्प्लिकेशंस होती है, पेशेंट सेप्सिस में होता है, ब्लीडिंग हो रही होती है, पास्ट कोई प्रॉपर हिस्ट्री नहीं मिल रही होती है, फैमिली को बहुत ज्यादा चीजें पता नहीं होती है, और यूजुअली हमारे यहाँ अनडायग्नोज्ड बहुत है ब्लीडिंग डिसऑर्डर्स, सो देयर इज अ कॉम्प्लेक्स सिचुएशन. तो हमें फिर वहां पे अदर ब्लीडिंग डिसऑर्डर्स जो होते हैं जिसमें एक्वायर्ड कॉजेज इज वेरी इंपॉर्टेंट, सच एज विटामिन के की डेफिशिएंसी है, डाइल्यूशनल कोगुलोपैथी है, DIC है. This should always be kept in mind for the diagnosis. So in the end, take home message क्या है इस presentation का? The take home message ये है कि evaluation of a patient with a possible bleeding history can be one of the most challenging referrals in the hematology practice. And a careful history will provide information on whether the patient has spontaneous or excessive post-surgical or trauma bleeding or has a positive family history of such types. And correct diagnosis is very important to diagnose the specific defect of hemostasis. और उसके लिए is very important कि हमारी laboratory testing is very important, और उस ताकि हम properly diagnose कर सके कि कौन क्या cause है bleeding का. Specialized testing is usually necessary to establish a specific diagnosis, like factor assays. मैंने आपसे कहा कि factor assays करने की बहुत जरूरत है. Mixing studies पे नहीं रोक दिया जाता है कि भाई ये factor deficiency है या ये inhibitor की वजह से है. We have to go forward and make a proper diagnosis to have a specific diagnosis. अगर specific diagnosis नहीं होगा तो patient की bleeding के जो management है ये properly नहीं हो सकेगा. इन सब चीजों के लिए हमें एक बहुत अच्छी अवेयरनेस चाहिए, एजुकेशन चाहिए, जेनेटिक काउंसलिंग चाहिए टू प्रिवेंट द स्प्रेड ऑफ सच कॉमन अकरेंस ऑफ दीज ब्लीडिंग डिसऑर्डर्स इन द कम्युनिटी. जैसे आपको मैंने WFH की फिगर्स बताई थी, और वो WFH भी आपको ये बता रहा है कि जो मेजॉरिटी पेशेंट्स हैं वो कहाँ हैं, डेवलपिंग वर्ल्ड में है. और डेवलपिंग वर्ल्ड में चूंकि डायग्नोस्टिक फैसिलिटीज इतनी अच्छी नहीं है और इट्स नॉट अवेलेबल एवरीवेयर, सो हीमोफीलिया के जितने पेशेंट्स होने चाहिए उतने नहीं है. So it's very important in Pakistan as well that we give a proper awareness, education and genetic counseling to increase the number of bleeding disorders. और जब तक हम ये properly diagnose नहीं करेंगे, proper management is not possible, and we will see all type of complications in these bleeding disorder patients. I am happy to take any questions if you have regarding my.
Thank you, Dr. Munira. Very informative talk on the coagulation, and the Dr. Munira, her excellent services in the coagulation field and the management in our society. Thank you, Dr. Munira. You touch the coagulation and the bleeding disorders from the very basic, and which may be helpful for the uh, trainee and the residents too. Thank you so much. The question and the answer session will be at the end of this session. Now, the third talk we will initiate is a very different mode of the hematology, that is the cytogenetics. The role of the cytogenetics in this era is a very, has for the prognosis is very important. The recently the TIH has developed a cytogenetics department, and as a full flash diagnose the cytogenetics and the report the patients on the pediatric BLL. So in this regards, Dr. Mahesh Kumar has very performance is a very superb, and the development of the cytogenetics under the shadow of the Dr. Sabah Jamal and Dr. Fatima Meraj. Uh, so I welcome to Dr. Mahesh Kumar for to unzip the standards regarding the cytogenetics. To welcome Dr. Mahesh and initiate the talk. Thank you.
Mera for a very overwhelming welcome. So today's my slide change नहीं हो रही. Sorry for the interruption. I'm just hoping that I'm audible and slides are actually shared with everyone. If that's not happening, please do let us know via your messages and all that. So that talk of my session is going to be the cytogenetics that is unzip the standards. So we all know that whenever we are going to initiate any test, that test has its own guidelines and standards. So there are guidelines which are defined, but there are certain guidelines which are not defined or established in the books. However, over the practice of years and years, uh, then then you come to know that of course technically there are certain factors which needs to be standardized for the reliability and accuracy of any testing. So today we are going to just touch those standards which probably you might not be able to find in the books or anywhere else, but these are the standards which have very terrible impact, which if we are not going to follow them. So the objective of my session is going to be to improve cytogenetic practices by adopting and monitoring of these testing standards. So there's a one thing that you have implemented, and there's another thing that if you are not going to monitor those standards or whatever you have implemented in your lab, then it's not going to work. So with implementation is the necessary, but however monitoring is much more necessary than the implementation. I don't have to anything further to disclose. So outline of my talk is going to be, of course, standards of the conventional karyotyping we are going to focus on, and the step which are involved in this testing and leads to the accuracy and reliability of results. So we are going to focus on those steps one by one in detail. So already I have told you that any lab, any good lab, the main objective of that lab is to give the accurate and reliable results. For that, that lab has to adopt the good laboratory practices, and GLPs, of course, contains the implementation of quality assurance standards. And then when we talk about the standards, there are some general standards which are common for the every any kind of test, and there are some technical standards which are specific to that test. So here we are just going to focus on those technical standards which are very important for the testing reliability and accuracy. So the first standard is, of course, we culture the sample for the karyotyping. So selection of culture media is a very important. The most commonly used practice is using of incomplete culture media. So incomplete culture media is mostly that is RPMI 1640. So for the good cell viability, we need to make that media complete in a sense. We need to provide the nourishment to the cells for their viability. So for that nourishment we need to add some external ingredients to make it a complete media, which are fetal bovine serum, antibiotics, and L-glutamine. So now if you see, we have some given percentages. So this is very important factor here. So when we are going to make it complete media, we need to have 80% of the media as a baseline, and then remaining 20% is going to be the rest of the ingredients. from out of which 18% should be the fetal buoyant serum, 1% antibiotic, and 1% L-glutamine. So this is very, very important, for the optimal cell viability. If that ratio is disturbed, probably we are not going to have the say good mitotic index at the end, and we are not going to have those complete 20 metaphases for analysis. And other thing is we can use the complete media. So the advantage of complete media is that we are not going to add anything uh, externally. So this media already has all those ingredients which are necessary for the cell viability. So but this is very costly, and probably these medias are not that much easily available in the market. So probably this is the reason it is not being used at the most places currently in Pakistan especially. So when we talk about the myeloid malignancies, so Meromex is the best media for the myeloid malignancies, because it has that certain ingredients which help to grow the granulocytes and its precursors and further stages. And then when we talk about the B cell malignancies, especially the mature B cell lymphomas and all that stuff, then Contimed is the best media to use for. So, and there is a Chang media. Chang media is a, it can good for the B as well as T cells. So now if we look at here, if we are going to detect the B cell or CLL, we are going to perform the CLL testing, then Meromex is not going to help us, because it has the ingredients which are specific for the myeloid cells. So of course this is not going to work for that. So we need to be very, very specific before culturing anything. We need to know the indication. We need to know that the indication is of the mature malignancy or the immature malignancy. So that's very important. And then once we are done with the media, then the sterility check of that media is very, very important, because the contamination, bacterial, fungal, any contamination of that media is going to terribly impact the your cell growth, and it's not going to give you the good mitotic index. So how we do it, the standard practice is that when you prepare the media, you have to take the aliquot of that media and keep that aliquot in your incubator for the 3 days. So for consecutive 3 days on daily basis, you have to check the physical appearance for any color change, clot, or any turbidity. So for 3 days, you have to keep checking that, and you have to log that in your logbook. Okay, for irrespective of if there is change or no change. So after those 3 days, you have to send that same aliquot for the microbiology department for the culture. So now we have WBC. So it is very, very important factor for culture inoculation, because once you know the WBC count of that sample, you will inoculate the accurate ratio of that sample to the media. It is very, very important factor. So for WBC, you can use your analyzer, or where you are actually unable to use the analyzer, then what you can do, you can go for just slide making and just have your that patient's WBC estimation on the slide. Then you can have uh, 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 like estimation of how much volume we are going to inoculate in that culture. So this is very, very tricky. So you need kind of expert person to have some accurate estimation, because the volume which we are going to inoculate in the media is going to terribly impact your cell growth. So calculating or knowing the WBC count of that sample is very, very important. So as we discuss, the WBC is going to tell you the volume of inoculation, and that again going to help you to adjust the media volume. If a WBC count is low, and then you can adjust your media volume as per your WBC count. So this is very, very important. And then we have a volume of culture media. So before initiation of any testing, we have to validate and decide that how much volume of media we gonna take for every patient, whether it can be 5 ml, it can be 8 ml, it can be 10 ml. But knowing and finalizing the volume of culture media is very, very important, because that media is going to give you the idea about the sample volume inoculation. This is very, very important for the good cell growth as well. So if you are going to take 5 ml, you are going to 8 ml, or you are going to 10 ml, it is going to tell you that the how much sample volume you're gonna inoculate. The standard practice or the recommended cells is what there should be 1 to 2 million cells per ml should be inoculated. That means if you have 5 ml media, then at least you need to inoculate 10 million cells for that media. And if you have 8 ml, if you have 10 ml, then this is the recommendation that at least per ml cells should be 1 to 2 million from that sample. And of course, then if you are going to follow that practice, then your sample is going to have an optimal biotic index, which will give you accurate and reliable results. The good yield you are going to have at the end of your testing, the more the accurate and reliable results you are going to produce. And then the type of culture, this is very, very important, because there are some unstimulated cultures and there are stimulated cultures. So unstimulated cultures are actually those in which we are not going to add the mitogenes. So these are, processed only with that your complete media and sample. And stimulated culture are those in which we are going to add the mitogenes, and we have to give them prolonged incubation period, at least 72 hours, because usually those are recommended for the mature cell process like B cell lymphoma, T cell lymphoma. So those are the mature cells, which need to go back into their cycles. So that's how they take the time to going back again into the cell division cycle. And that's why we have to at least provide them 72 hours for their that phase. So for the acute leukemia, in unstimulated cultures is the standard practice, and this is most recommended practices, because acute leukemia, they have the cells which are self proliferating, so we don't need to stimulate them. So that's why selecting unstimulated cultures, this is recommend that at least you should process two cultures with every sample. Because if you are going to have only one culture with each sample, then that culture, something can go wrong with that culture. Like that culture can cannot grow well, that can contaminate. So if you are going to have at least two cultures, then at least you are in case if one culture is getting damaged, then you will have at least second culture to give the results. This is the one benefit. And the other benefit is, when you have one culture, what you do with that culture, you expose that sample with the calcimate for a prolonged period of time. In that, doing that, you will have good mitotic yield, because calcimate is gonna arrest them at the metaphase stage. Then in that case, in this culture, you are going to have a very good mitotic yield. The drawback of this prolonged calcimate exposure is, in that culture, you are going to have a small chromosomes which are not suitable for the identification of subtle or micro deletions. So in that case here, your culture too is going to help, because you are not going to expose that culture with the calcimate prolonged for the prolonged period. You add calciumate for the short timings, at least the 2 hours before the harvest. It will give you low mitotic numbers, because here we have very short calciumate timing, but with the low mitotic index you have a long or elongated chromosomes, which are good for the subtle or identification of the micro deletions. So having two cultures is going to help you out in every aspect. So now if we come about the stimulated cultures, so for B or T malignancies, these are the recommended. If we have B lymphocytes, so we can use or add the mitogens which are good for the B lymphoid malignancies. These are the CpG or IL-2, and for the T lymphocytes, the mitogen which is the best is PHA. I'm sure the most labs are using the PHA for any kind of stimulated culture, but I would suggest this is not a good practice, as PHA is only specific for the T cell malignancies. So if you are having a CLL patient and you are going to inoculate that sample with the PHA, then this is not going to work. In that case, what will happen? This is going to stimulate the T cells, and the malignant B cells will die in that sample, and T cells are gonna stimulated, and you are going to have metaphases from those T cells, which will give you your false negative results. So knowing that which mitogen is best for the which cell line is a good tool, right? So now I told you that for acute leukemias, unstimulated cultures are the very best. So mitogenic, our stimulated cultures are not good for acute leukemias, because mitogens have tendency to sometimes they can give you or produce the artifactual results. So that's why acute leukemia, they are self-proliferating cells, they are self-dividing cells. So that's why we don't need to add any kind of mitogen to stimulate them. Now once you are done with your culture, the harvesting is very very important for result reliability and accuracy. So in harvesting, the two steps are very crucial. One is the KCL time. You need to adjust and validate your KCL time. It can be 15 minutes, 20 minutes, 25 minutes. So it is variable from lab to lab. So that's you have to validate. And then the ratio of fixative is very very important, that the ingredients you are going to fix your cells. And then this is important to know the 1 to 3 ratio, or 2 to 3, or 4. And then when you are going to drop your slide, the role of temperature and humidity is very very crucial. So if you look here in the slides, so when you are lower the humidity, lower the percentage of humidity, is going to give you the less spreading of the chromosomes. Your chromosomes are going to be in the clusters. So if you look here, so this is the humidity is less than 30%. So we can see the chromosomes are overlapped almost, they are not well separated. So when we have increased our humidity more than 30%, but still it is less than 45%. Chromosomes are separated, but still those are overlapped. So when we have humidity 45 to 50%, chromosomes are well separated, but still there are some chromosomes which are overlapped. So when we have humidity more than 55%, so now we can see that each and individual chromosome is very well separated. So giving the required or optimal humidity to the cells at the time of dropping is very very important tool. So the recommended temperature and humidity for that area in which you are going to drop your slides, your humidity should be 45 to 60%. And then we have band resolution. Of course, this is very very important. The more prolonged or the more band resolution you have, the more you are able to pick up your subtle and micro subtle abnormalities and micro deletions. So when you are going to process your hematolymphoid bone marrow, the recommended band resolution is 400. And then when you are going to perform your constitutional, the recommended band resolution is 550 at least. So this is very very important, to be accurate and reliable in your results. And then analysis. So of course, you need to involve at least your two technologists in the analysis. This is CAP recommendation, this is your European Cytogenetic Association recommendation, because in case if one person is missing something, then other person will be able to find that abnormality. So this is how this will increase your confidence interval of your your reporting. So you need to involve at least your two technologists in each case. Every technologist has to identify or analyze at least 10 cells. So in that you will have a 20 metaphases for the analysis at the end. And not just involving two technologists, but analyzing like all cultures from every patient is very very important. Like if you have processed any sample with culture 1, culture 2, culture 3, then all cultures should be reviewed and analyzed, because sometimes you might find some artifactual abnormalities which will be present only in one culture, and then the rest remaining culture will be normal. So correlating all cultures is very very important tool as well. And now your report should be a very descriptive, very explanatory, very it should contain clear ISCN, and then explanation of that ISCNR findings, and the comment that the impact of that findings on the patient's disease outcome is that should be explained very well. So based on these standards, we have been what we have been practicing. I'm just gonna present some audit of our department. So this is what the culture stability check. So this is our microbiology department report, and we have this routine practice whenever we are going to make a new media. So we are going to do this or follow this actually. So in last 10 or 12 months or 15 months, we don't have any kind of culture contamination. So this indicates your the strict following of the sterile techniques which you need to follow during every step of your testing. And this is G bending quality log. We have what we do first, we run 3 or 4 slides for the bending as a QC check, and then on the different seconds, of course. So we then we analyze or observe those slides under the microscope. Then when we find our optimal bending at the required seconds, then we follow our we stain our patient samples with on those seconds actually. So so whenever we are going to have anything any event, so we are going to document that event in a logbook, and we just go for the root cause and corrective actions based on this. And this is culture failure log. We are following since day one. So here what you see is orange is basically the cutoff, and blue is our departmental performance. So so the culture failure log, the recommended cutoff is it should be less than 5%. So if you see, we are just we are just meeting our that cutoff level, and we are falling in that that standard. So this is very very important. By doing that, you will come to know that the kind of samples you are getting, those are either QNS, low volume, low count. So in that way, actually you are going to help the clinician from where you are receiving your samples, that you can intimate them that please look at your procedure technique. We are getting our most of the time we are getting suboptimal kind of samples. So this is just not going to help you as a technical personnel, but you are going to help as the clinician as well. So the take-home message: result accuracy and reliability, of course, highly dependent on quality of metaphases or chromosomes, which is totally dependent on your composition of complete culture media. Sterility checks is very, very, mandatory step to go for. Then WBC count is very, very important tool to know the final, volume inoculation. And then type of culture, by knowing the indication of disease of the patient which you are actually going to process. This is very, very important. By doing that way, you would come to know that we are going to process with the unstimulated or stimulated cultures. And then the time of KCL is very important. Then at the time of slide dropping, controlling temperature and humidity before dropping has a very good impact on spread and morphology of chromosomes. So of course, G-banding is, this is the utmost thing to, monitor. And then involvement of at least 2 cytotech in each case is mandatory. It will increase your confidence interval, and a concise final detailed report, it will help the clinician, to tackle the disease and its follow. So thank you so much. Thank you.
Thank you, Dr. Mahesh. You very interesting talk, and the topic you really unzip the standards of the cytogenetics and how to implement the cytogenetics in organizations or in the hospitals, and how you maintain the stability and the quality check. Uh, Now it's a time for the new emerging marker, that is the monocyte distribution worth. Many people hear this word, and the many people are not aware of this word. So in this talk, we will present the role of the MDW, that is the monocyte distribution word, in the screening of the sepsis, and you can uh, detect or the diagnose the sepsis with the routine CBC through the MDW. So I will talk request to Dr. Sumera, as I am a Dr. Sumera as a consultant hematologist in this hospital, to please talk on this topic. Thank you. Assalamu alaikum. This is me, Dr. Sumera. I am a consultant hematologist, Mera Shaikh, consultant hematologist at Indus Hospital, Karachi. Today, my topic of the presentation is monocyte distribution with a novel biomarker for the early sepsis screening. First of all, the important thing is the what is the sepsis. A very challenging thing is what is sepsis. Sepsis is the body's overwhelming and the life-threatening response to infection that can lead to a tissue damage, organ failure, and the death. In other words, it's the body's overactive and the toxic response to an infection. Sepsis is a medical emergency that requires a rapid diagnosis and the treatment. Therefore, a sepsis can be lead to a severe sepsis and septic shock if it not timely managed and diagnosed, then it could be a lethal disorder. For the clinical perspective, the important thing is to how to diagnose sepsis, because it can convert timely diagnosis and the promote management of sepsis is an important component for the stopping of the progression of sepsis, as patient within a 72 hours it can be convert from severe sepsis to a sepsis shock. So in clinically grounds, a time which is a very important in the sepsis. Here the time represents the temperature. If temperature is higher than the normal range, if patients become infective and he or she is presents any sign or symptoms of the infection, if patient is declining their mental status, either he is drowsy, sleepy, or confused, it's also indicator of the severe sepsis. Or a patient is severely ill, feeling a pain and the discomfort or the shortness of breath. So time here works a lot for the management of the sepsis. Clinically, sepsis categorization, which is totally dependent upon this type SOFA. You know, the SOFA is a totally is a scoring of the sepsis categorization, which consisting of the blood pressure, mental status, and the tachypnea. If SOFA becomes more than 2, then it's considered as it has a higher risk of the organ failure and becomes a poor outcome. So when patient comes with an infection, the clinician first of all see the signs of the sepsis. If he or she is converting a septicemia like fever, tachycardia, or the tachypnea, or the possible source of the lung or the urinary tract injury and the organ failure, then he think about if organ dysfunction occurred, then he investigate this could be a sepsis. So he ordered many things for the diagnosis of the sepsis, like CRP, PCT, which are the established biomarkers for the diagnosis of sepsis, and sent samples for the microbiology lab. So the lab diagnosis helped out clinicians for the diagnosis. But one thing is very important, which is coming soon, is a sepsis. So new sepsis biomarkers are established for the diagnosis and help out the physicians or the clinicians for the management, for the proper treatment and the management of the sepsis, like PCT, CRP, lactate levels, and WBCs, which I have cleared in my last slide. Among the all these things, the PCT has a more wattage, is considered as a gold standard, and rest of the tests. It's a because it's a very sensitive and specific. It's as measurable, available होता है, supportable, responsible, and the responsive and the reproducible, and the its guidance time. It's all these things are the well proven by the many literatures. But there are the few limitations of the PCT. One, it's expensive test and it can be falsely positively high in like non-infectious conditions like trauma and the CKDs. So there should be a need of to bring a new septic markers which are more reliable, cheap, and then expensive. So, in respect of these things, one challenging marker has up in the market, which brings by the Beckman Coulter in a DXH 900 analyzer, and they give a new marker is the MTW, which measures a monocytes, activated monocytes, and they claim that this is a new upcoming septic marker. So first of all, what is monocyte distribution width? Is an in vitro diagnostic parameter that reflects the change of circulating monocytes volume in response to a pro-inflammatory signals from infectious organism referred to as a pathogen associated molecular patterns. How it works? When PAMP is a pathogen associated molecule arises, then many interleukin B releases after the cleavage and the caspac activation. Then, after the infection, the immune dysregulation has happened. When inactivated circulating monocytes becomes activated, and when they become activated, and they can cause the organ failure, and then we label as the sepsis. So in a sepsis, the main activated monocytes played a role to raise the MDW. How it analyze, how it should be analyzed in DXH 900 hematology another, which is the Beckman Coulter is capable of automatically reporting the MTW parameter as a part of the complete CBC count with the white blood cells, differential hematology another from whole blood mass sample. Yes, in this parameter, there's a one thing is very important that we have no need to any preparation of the test or the order or the financial. It can be reported with the CBC sample. This is the window of the DXH when they give as the CBC. In the routine CBC parameters, they reported as the MDW, and with this paragraph, these. So this is the a picture of the instrument. How can be what are the intended use of the MDW parameter? Because FDA now is after a big debate, FDA has cleared that MDW can be used as a parameter for the emergency department for the differentiate between the early detection of the sepsis or in the developing sepsis. How it works. Beckman Coulter utilized the proprietary VCS technology to categorize the WBCs in the near-native states and the separate differences type of the WBCs in order to generate a 5-part differentials: neutrophils, eosinophils, monocyte, lymphocytes, and the basophils. Through these measurements, the system gathers information about each of the WBC population, including the mean and the SDs for each of the measurements, and refers to the cell morphometric parameters formerly known as the cell population data. Monocytes and neutrophils represent the first line response during the infection by the pathogen, and accompanying the inflammatory process may result in the activation and the ultimately morphological and the functionally changes has happened. These morphological changes in the slide ones that are detected by the priority and neonatal state characterization by the capability. These are the pictures in of the Beckman Coulter. The two cases, the septic and the non-septic. Here are the monocytes monocyte volume within, they are the compressed, and they are no the width has become not increased, and but the hair the septic where the cars increased MDW, and their hair is the non-septic, in which there are the MDW, the width is not increased as compared to this. Now, question is, why should clinician order this? The answer of this is the because this is the cheap test. It can be available under routine CBC. There is no preparation for the this test, and there's no extra money has to be charged by the patients. And and the other ways is a large clinical need for the redetection, and because patient or the clinicians needs the one parameter which can detect early sepsis in cheap rates and emergency grounds, and emergency departments have initiated a major detection as early as possible because reliable microsepsis is lacking. Existing biomarkers of sepsis such as PCT and the lactate are ordered only if the clinician has already have a high index of the clinician suspicion of the sepsis. Most critical needs are the identification and the alerts of the sepsis when the physician does not suspect this. Yes, this is the important things when the clinician has not aware of any septic condition because patient has not clearly developed the sign and the symptoms, then this marker play a role. Now, what challenge is this? Where diagnostic uncertainty is a major challenge for the patient presenting in the sepsis who are low number of sign or symptoms or without the sign and symptoms of the sepsis. Here I present one of the study which is performed in our setup. We include data of the July to October 2022. This is short data, only a limited number of the patients were included, around 111, and we exclude all the patients who have a neonates and the hospitalization of the less than 24 hours and the without clinical sign of the sepsis. We included labeled patient of the sepsis who are suspected, clinicians suspect the sepsis on these patients, and the hospitalization is more than of 24 hours and with fever. Uh, then we clinicians perform the PCT levels, CRP levels, and the CPC levels, in which the routine we categorize them as a WBC, which are categorized. These are the levels which are considered as a positive for the PCT is a 0.05 nanogram per ml, and the CRP is 0.5 milligram per liter. And the WBC as is established, there is a biphasic role. WBC can be low in the high, and the MTW can be high in the 20, more than 20 BC. From Meissner and Pro Calciton is one of the study as performed by the biochemistry and the clinical diagnostic, which is published in the 2010, and they categorize the PCT values in the 4 categories. They consider on the clinical background. If less than 0.05 nanogram, they consider as a healthy or the negative. And when a patient develop as between 0.05 to less than 0.5 nanogram per ml, then systematic infection is unlikely. However, localization infection can be a possible. Here, clinicians suspect any infection, then he, or most of the time, they ordered or prescribed certain antibiotics to treat the patient infection. And level from zero point 0.5 to less than 2, the systematic infections are possible due to other conditions. The major trauma, recent surgery, severe condition may be also induce significant PCT rise. Here clinicians becomes alert and they consider as a low category sepsis. Between 2 to less than 10 nanogram per hour, systematic infection is likely, so they consider it as a sepsis, and more than 10 nanogram, high likelihood of severe bacterial sepsis or the septic shock. This is the most severe category of the PCT. By through these value, we analyze are the septic patients, the triple one in this study. In our study, males were the 55 males, the 49.5 percentage, and the females were 56, almost just a similar spectrum between the male and the female. And among them, pediatrics were the 13, and the adults were the 98. 88.3 percentage were the adult, and the 11.7 percentage were the peers. The median interquartile age is between the 3 years. However, in adults, the median interquartile age is the 55.5 years. We see the PCT in our study as a 01.74 has a positive. So this the positive we consider as a positive. The positive cases were the 92, 82.9 percentage, and the negative were the 19, 17.1 percentage. And however, the CRP were the positive is a 66, 85.7 percentage, and the negative were the 11, 14.3 percentage. And the WBCs we found the 40.5 percentage for the normal WBC is reported, and the abnormal is a 59.5 percentage in our data. We found MTW is a 24.9 units between us, and these results of the study parameter being represented in the by the interquartile ranges. When you plot the ROC curves between the correlation for the MTW and the PCT, and the we seen that this one is the area under curve. Take care, we seen the sensitivity, specificity area under curve. The MTW was found to be comparable with the VCT is a significant as a significant p-value. As the specimen was between correlation was the very good, and you can see here there's a correlation was very good, and how they are between these two parameters are positively correlate between these two. In current study, MTW of the 22 more than 20.0 was the cutoff value with the maximum sensitivity is 86.96 and specificity was a 73.68 percentage. So there's a positive correlation among the MTW and the PCT was observed in this study. Again, from this study, we correlate the MTW with the well-established other marker CRP. And we saw the area under curve was also good, but so good, but it could be but insignificant here is a show because the number of the CRP was prescribed by the clinician as a low as compared to PCT. So the low number were the CPC. So in this study, we can conclude this by if we take a large sample area, a large sample size to perform the correlation between the MAW and the CRP. As you know, the CRP is not is established septic marker, but it standardization as compared to the PCT is low because it can be raises in other than the other than the septic condition. So clinicians nowadays prescribe mostly a gold standard parameter, but our MDW mostly shows a good correlation with the PCT as compared to CIRP, which could be due to a low sample size. Again, we see the WBC. As you know, the role of the WBC in the sepsis is not clearly established. It can be a low, it can be high. However, we see between the correlation between the MDW with the CBC also, which also shown in the insignificant. As already this is well not established or proven septic marker at all. Here we see the categorization on the different groups of the PCT as I described previously. That PCT has categorized on the clinically background where the negative and the positive is further considered as a group 1, 2, and the 3 and the 4. So we see this sensitivity and the specificity among these. This is the negative PCT. Here we see the sensitivity on the negative PCT with the MDW is around the 53.85 at the 95% interval, and the specificity is become 86.8% and 94 times when it's more specific at the negative. And the second group, when the borderline sepsis or PCT has been raised, we saw in that cases, 56 cases were the major data of our fall in this category, around the 56 patients. Here, the clinicians most of the time not prescribe anything because they consider as any localized infection. So in this category, PCT with MDW, they show 83.9 percentage of the sensitivity. It's a good sensitive. The correlation is again, and the sensitivity is a match, and but the specificity is 73. It could be anything, whatever. So. And the second group is considered as a when the low category of the sepsis as a zero point 0.5 to less than 2. Here again, we have a limited number of the patients is fall in this category, and we saw the MTW is 93 percentage sensitive in this category, and the 73.68 percentage is specific in this category, and the between 2 to less than 10. Again, there is a small number of the samples, and the could be not more representative, but is a 70 around in the sensitivity and specificity fall in the 70s category, and the more than 10 where the septic shock clinician considered as a septic shock, only 11 patients fall in this category, and the hair is a surprising result. The sensitivity of the MBW against in this category becomes 100%, while the specificity is fall in the 73%. Here are the different and the way you can see the ROC curves and regarding these categories, and these look at the behavior and the significance pattern. They have the significance. This is the main slide of the this study. There are the where various parameters were measured as sepsis time as ROC. So the MTW has a 95% confidence interval, has p-value. This is significant. You can see this is the blue. The how far is this is the intersection. How is the far away, and how this is correlating this. And this is the PCT, and the green one is the PCT. You know the MDW and the PCT are behaving like similar pattern with a similar pattern, and they are correlating with each other, and they are mostly far away to this. However, WBC and the CRP has some not these are the very nearest to this, and they are not good response. However, with the correlation with the MDW with the PCT, they have a good correspondence. We compare this our study parameters with our study. They have limited data, as this is a new novel biomarker, so limited studies were available. However, in our study, as when we checked that all parameters were the match with each other, the numbers were matching with the WBCs as the MDW with the PCT and the MDW with the CRP as a correlation. Here is favoring as a response to the rest of the other studies are reported in the 21 and the 17 and then. So, however, we in our study we found that the cutoff is 20 in the septic patients rated. If more than 20, we consider it as early sepsis. And however, this can be a similar way rest of the studies have done in a 20 and the 2021. So we have a similar pattern. However, this is a limited number of the samples we have included in this R study. So could be for the reliability or the sensitivity and the specificity and the establishment of the cutoff, we should take a bigger sample to prove this as a early septic marker. However, we saw in our data the sensitivity and the specificity in context of the PCT and their levels and the categorization of the sepsis which have which is a more important, which I've never done in any other study, but we saw these. But due to a limited sample, it is not truly established, but it can be seen. We can say that the MTW is a positively correlated with the PCT in the emergency settings or in the where the clinician is suspecting sepsis. So before waiting to patient converting or developing a sign symptoms or converting a septic shock, they can see MDW and the manage or the diagnose according to the MDW levels, because MDW has a good and the positive correlation with the gold standard well established biomarker of the sepsis. Thank you so much. For any question, you can come. Thank you. Hopefully, this talk is very informative, as in the medicine or in the sepsis, because MDW, which is a very cheap marker and which can be availed in the routine CBC, and hopefully. It will helpful for the physicians, as is this is a new marker, so more further studies should be done in this era to prove this. However, coming to the next toss, which is the, I think I call it a theme of the today's session, because the here we suggest the how the role of the integrated report. The now this is era is not only a consisting of the hematology, is not only consisting of the morphology you diagnose it, but many complicated cases and the challenging cases, in which we need for the diagnostic tools, the more specialized diagnostic tools, and how the integrated department or the multi departments and the multi technical tools can help to diagnose these type of the rare cases. So here is a very uh, 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 interesting and the challenging cases. Dr. Neelum Mansoor is bringing the challenging cases for today's session. Doctor, before starting her talk, just a brief introduction to the Dr. Neelum Mansoor. Dr. Neelum is a consultant hematologist in the Indus Hospital, and she is I think has a very good role in the every department of the hematology and the blood center. Currently, she is also trained by the Cytogenetics departments, and she's also in reporting these as a new challenging cases from the Cytogenetics department. And now I will call Dr. Neelam to please carry on the interesting cases. Thank you.
Assalamu alaikum. Good morning, everyone. I'm Dr. Neelum Mansoor, and today I'm going to talk about integrated diagnostic approach in hematology. But first of all, I would like to thank committee for giving me this opportunity to talk about this important topic. So I have nothing to disclose. So what is the normal process of a healthcare system? We all know about it, but this is a simple overview regarding when a patient has a problem. He came to a healthcare system, and then on the basis of the clinical judgment, working diagnosis is usually made, and then different samples are sent to the laboratory, and some imaging investigations are requested from radiology. And on the basis of all these workup, a combined approach towards the diagnosis is adopted by the clinical team as well as the diagnostic team, and then we proceed towards a working diagnosis. And after all the information gathered, integrated diagnosis is communicated to the clinician, and then they start their treatment plan and assess the prognosis and the outcome depending upon the disease type. So we all know this and we are well aware of all this system. So being a part of a laboratory and a pathologist, first of all, I would like to share that laboratory is comprised of a huge sections. You can see there are multiple sections that work in close association with each other. And to convey a diagnosis, there is a lot of effort that is going on in every section. So the broad term of pathology is comprised of a lot of sections that includes hematology, not only hematology, it also includes clinical expertise, that is a part of clinical hematology, diagnostic expertise, that usually practiced by a hematopathologist, histopathologist, and our medical microbiology, transfusion medicine, clinical biochemistry, a lot of departments are working here in laboratory, and this is a teamwork that usually leads to a accurate diagnosis. So if you talk about the topic of today's talk, I'm going to talk about impact of an integrated pathology approach on the diagnosis. So the concept behind this diagnosis is what? One patient, one diagnosis, and one report. And what are the parameters which leads towards this concept? That usually, as I already told you, multiple samples are received in the laboratory, multiple testing modalities work towards the results, and there are multiple sections of laboratory which are involved, and interpretation of a wide range of techniques and a wide range of results, which which leads to integration process. And on the basis of all this process, a comprehensive integrated report that should ideally be made. But in actuality, we are not working in this way, and integrated reports are usually not prepared in our departments. However, we are moving towards this, so that we can achieve diagnostic accuracy, as well as the clinicians can move towards the targeted treatment on the basis of this comprehensive reports. So in my today's talk, I'm going to talk about a few cases that I will be sharing here. And these are not the usual cases. Like in some cases where usually we just get a sample and we get results just in few hours or few days, a straight diagnosis is usually made and treatment is usually started. But here in these cases, multiple sections of laboratory work and after a huge workup by different sections of laboratory, a diagnosis was made. So here, this is my first case. Here, this is the first case where the patient was presented, a 61-year-old male presented with anemia, fatigue, abdominal pain, productive cough, and weight loss for 5 months. On examination, there was internal lymphadenopathy and massive splenomegaly, and there was a clinical suspicion of carcinoma of lung. While on the basis of radiological findings that includes X-ray chest, which showed right-sided consolidation, and CT scan test that revealed organized right-sided pleural effusion with cicatrization in upper, middle, and lower right lung. So the first step towards the diagnosis was pleural fluid aspirate, which was received in our histopathology department for cytology. So these are the images of cytology site, and here you can see that large atypical cells were present. However, the report was inconclusive as the cell block could not be prepared and immunohistochemistry was not performed due to scanty material. So the diagnosis was still pending. After that, we received excisional biopsy of inguinal lymph node in histopathology department. Again, these are the slides from histopathology department where you can see the low power images of lymph node, which showed effacement of nodal architecture, and that was secondary to extensive fibrosis. These are the HME stain sections of lymph node, which are showing large atypical cells in the background of fibrosis. So panel of immunohistochemistry marker was performed, keeping in mind the initial diagnosis that was carcinoma of lung. So the initial panel includes CKAE1, AE3, CK7, and all that. And all the panel was negative. The second panel, considering the large atypical cells, was ordered. That includes Hodgkin and anaplastic large cell lymphoma was in the mind. Most likely, our histopathologist was working on it, and they ordered the second panel, which was again negative. So the third panel was ordered to exclude the possibility of hematological malignancy, and again, all these markers were negative. So as last resort, the only marker ordered in the fourth panel was CD61 that was positive. These are a few examples of the immunohistochemistry slides. You can see CKAE1 and CD34 both were negative, however CD68 and MPO, they were scattered positive. So these are the images from CD61, and you can see it was positive, bright positive in megakaryocytes, highlighting scattered as well as loose clustering of megakaryocytes in lymph node. That was quite an unusual finding. So the report was concluded as extensive fibrosis and extramedullary hematopoiesis in lymph node, obviously, and the clinical correlation advised. And the most important thing the histopathology department recommended is bone marrow biopsy. Then bone marrow biopsy of this patient was received in hematology department. This is the blood film of the patient received with the bone marrow biopsy, and the CBC parameters were hemoglobin 8.6 along with leukocytosis, leukocytoplastic blood picture, left shift, circulating blast were also there, and platelet count was normal. In the blood film, you can see there was an isopoikilocytosis along with numerous teardrop cells. You can appreciate here by the arrows I have highlighted here, and the leukocytoplastic blood picture. Absolute basophilia was also found in the smear. This is a bone marrow aspirate. It was paucicellular and hemodiluted. Only on megakaryocyte you can see it was hypologated correctly. These are the HLE sections of bone marrow defined, and you can see there is effacement of normal bone marrow architecture, and it was due to streaming of cells that is reflecting background fibrosis, and the thickened, broad, and irregular trabeculae that was appreciated. And you can see this bony trabeculae is occupying more than 50% of the bone marrow space. Here you can see the presence of megakaryocytes and myeloid precursors inside the sinuses, and this is a very strong clue towards the presence of extramedullary hematopoiesis. This is the reticulum stain. Diffuse and dense fibrosis is noted in reticulum stain, and an unusual finding was new bone osteoid, a large area showing osteoid formation in all the sections you can see. So on the basis of WHO classification of semi-quantitative grading of osteosclerosis, the case was in grade 3 that showed extensive interconnecting meshwork of new bone with overall effacement of marrow spaces. Sorry, grade 3 extensive interconnecting meshwork of new bone with overall effacement of marrow spaces. So the panel of immunohistochemistry performed on bone marrow biopsy includes immature markers, TD gene CD34 that was negative, B lineage markers both were negative, and CD61, which showed increased positivity, highlighting loose clustering, micromegakaryocytes and megakaryocytes within the sinuses. These are some images from CD61, and you can see the clusters and the presence of megakaryocytes inside the sinuses. So in summary, the bone marrow findings were fibrosis, prominent sinuses, including immature hematopoietic precursors present inside the sinuses, and increased megakaryocytes with atypical micromegakaryocytes as well as clustering. So at the same time, we received cytogenetics workup in our cytogenetics department that includes fish and carrier typing. Fish received for BCR-ABL1, and it was showed no evidence of BCR-ABL1 fusion gene. And however, in conventional karyotyping, there was a very important finding that showed 46XY. It was a normal male model, and however, there was a translocation, a balanced translocation between long arms of chromosome 4 and long arm of chromosome 12. While there is an unbalanced translocation that results in derivative chromosome 6, resulting from long arm of chromosome 1 and short arm of chromosome 6. So, as per WHO classification, the presence of derivative 6 along with translocation 1,6 is strongly suggestive of primary myelofibrosis. And the most common recurrent abnormalities are deletion 22 and partial trisomy 1 that was present in our case. So we concluded the case as primary myelofibrosis and extramedullary hematopoiesis in lymph node. That was the presenting feature of the case, and it is a very unusual finding for myeloproliferative neoplasms. We recommended further work of JAK2, CALR, and CMPL for further categorization. And at the same time, before signing off the final report, we researched a lot of literature, and we found a recent review article that that were talking about extramedullary hematopoiesis and myeloproliferative neoplasms. And as we all know that extramedullary hematopoiesis in an adult is always pathological. However, it can see in various physiological and some other hematological malignancies, but it is mostly associated with myeloproliferative neoplasms. This is another case report recently reported, and it is more or less similar to our case. And again, in this case, there was a patient with primary myelofibrosis who was presented with generalized lymphadenopathy secondary to isolated extramedullary hematopoiesis as an initial manifestation. So, and in this case, again, the lymph node biopsy showed no evidence of malignancy. However, large atypical cells, like in our case, were present, and on the basis of pulmonary examination and and cytogenetics workup, they concluded the case as primary myelofibrosis. This is another article recently published in Blood, which we found inconsistent we found this article in accordance with the cytogenetic findings reported in this case, and the article says that advanced forms of myeloproliferative neoplasms are associated with chromosomal abnormalities involving long arms of chromosome 1 and 12. So, as we all know that loss of TP53 function plays a critical role in cancer biology, and the major protein regulators are MDM2 and MDM4. TP53 activity has been reported to be downregulated in myeloproliferative neoplasms due to overexpression of MDM2. And since the gene of MDM4 is located on chromosome 1q and the gene for MDM2 is located on chromosome 12q. So the cytogenetic abnormalities involving these locations might lead to disease progression. So after the combined effort from histopathology, hematology, and cytogenetics, as well as cytopathology, on the basis of all these findings, we concluded the case and established a diagnosis in this case. Otherwise, it was not possible if we were working in isolation and sending out the histopathology report in isolation, and if the bone marrow biopsy was not advised on the basis of extramedullary hematopoiesis, then we could have missed this case. This is another case. A 7-year-old female patient presented with complaint of fever for 2 months, and the family history was unremarkable. On physical examination, cervical lymph nodes were palpable, and the spleen was also palpable 8 centimeters below left crystal margin. In diagnostic workup, first of all, we received CBC, and this is the image of blood film. Here you can see hemoglobin was low, 8 gram per deciliter, TLC was 1.1. However, platelets were normal. So it was bicytopenia, along with no significant findings in differential count. Legal diagnostic picture was appreciated. So bone marrow biopsy was performed on the basis of CBC findings. This is the slide of bone marrow aspirate. It was paucicellular and hemodilated touch imprints Again, testing print does not show any added information. It was more or less similar to bone marrow aspirate, just showing few mild white precursors at different stages of maturation. This is the lower hypertrophy of bone marrow refined biopsy. It was cellular and retically stained through grade 2 fibrosis. The panel of immunohistochemistry marker includes immature markers, B lineage and T lineage specific markers, MPO and CD117 for myeloid disorder, and CD61. That was bright positive and showing extensive infiltration by monokaryocytes, and a huge area of clustering is also appreciated. So if we summarize the findings of bone marrow, the aspirate was hemodiluted, bone marrow refined was cellular with increased megakaryocytes, which showed hyperlobation and bulbous cloud like nuclei, and significant clustering was also there. So on the basis of CBC and bone marrow findings, our differential diagnosis was primary myelofibrosis, childhood MDS, and metastatic disease. So at the same time, along with bone marrow biopsy, the workup received in cytogenetics department was communicated to hematology for the confirmation of diagnosis. And then we came to know that the fish received for BCR-ABL1 fusion gene was positive in this case. It was quite surprising for us as the marrow findings, particularly the CBC findings, were not supportive of CML. You can see here the very clear dual fusion was present in this case, and KV-type results were inconsistent with a fish, and classification 922 was appreciated. Then again, the case was not fulfilling the criteria on the basis of morphology and hematological parameters. So we sent a sample for PCR to get confirmation of PCR ABL1. Although the diagnosis was made CML, but still we got confirmation, and the PCR analysis also showed PCR ABL P210 transcripts. So by all this combined effort from hematology, cytogenetics, and molecular genetics, the case was diagnosed as CML. So again, in this case, we went for the literature search as the TLC count was very unusual for a case of CML, and then we found that the pre-leukemic phase of chronic myelogenous leukemia. It was reported. A few years back, and they reported 7 cases with CML patients, and sorry. Then we went for a literature search, and we found a term of pre-leukemic phase of chronic myelogenous leukemia. And in this article, we reported 7 patients who were diagnosed with CML, and they were presented with normal or mildly elevated WBC like in our patient, and the patients were asymptomatic, and however, cytogenetics workup revealed presence of classification 922, and that was further confirmed by BCR-ABL fusion gene analysis by FISH or PCR. So the cases like this reported, and in these kind of cases, integrated approach is very important. So this is the case 3, where a 73-year-old female patient presented with fevers, annualized treatments, and epigastric pain for 2 weeks. And she was a known case of chronic kidney disease. Physical examination revealed generalized lymphadenopathy and hepatomegaly. Radiological findings revealed radiological findings showed mild hepatosplenomegaly and enlarged lymph nodes at paraaortic, axillary, and mediastinal regions. In diagnostic workup, first of all, we received CBC. This is a picture of blood film. And you can see that it was normocytic monochromic with anisocytosis and homochromic anemia. And TLC count was raised, that was 27.9, along with absolute lymphocytosis, and that was 14.8. So the request of flow cytometry is received on the basis of absolute lymphocytosis. So there was a clinical suspicion of lymphoproliferative disorder. So we performed a huge panel of immunological markers and flow cytometry, and the all available markers of T cells and NK cells were tested in this case. As you can see here, the red population is the population of interest, and it is positive for T cell markers, that is CD3, CD7, and CD. 4, 8. In this dot plot, you can see the population is positive for CD8, however, it is clearly negative for CD4. The green population is the benign T cells. So if I summarize the findings of flow cytometry, there was 45% small residual lymphocytes, and our initial panel that includes all T cell markers, CD3, 5, 7, 2, 8, and TCR alpha beta, all were bright positive in this case. So in the second panel, we tested different markers for all of the possibilities, including immature markers that were negative, CD1A, that was immature marker for T cell, which is negative, CD4 was also negative, NK cells markers, that is CD56 and CD16, both were negative, and CD25 and CD30, and as well as CD15, all were ordered keeping in mind the chronic T cell lymphoproliferative disorder. All these markers were negative. So our conclusion was T cell lymphoproliferative disorder, but the question was clonality, whether it is a clonal process or it is a reactive phenomena. So we could not get the answer, and at the same time, an excisional lymph node biopsy was received in histopathology department. So these are the images of cervical lymph node biopsy, HLE stain sections at lower and high power view. And you can see there is diffuse effacement of normal nodal architecture by sheets of polymorphic intermediate to large sized atypical cells. These are the panel of immunohistochemistry which was performed on cervical lymph node. And here you can see the diffuse blood positivity of CD3 and CD8, while the rest of the markers were negative, and Ki67 was 60 to 70% positive. So the lymph node biopsy findings include effacement of nodal architecture, and the panel of markers for T cells was all negative. However, the extended panel that includes imaging markers, BVDs markers, and other markers that were considered on to exclude chronic lymphoproliferative disorder T cells, all were negative. But still there was an edge of morphology and replacement of architecture, and on the basis of the combination of all these findings, they concluded the case as peripheral T cell lymphoma and suggested the molecular studies for T cell receptor gene rearrangement. As you know, that flow cytometry is way more sensitive than immunohistochemistry, but in some cases, the old strategies are still very useful. And in this particular case, that we see on the basis of the morphology, the effacement, and the pattern of involvement, and the pattern of immunohistochemistry, they comfortably concluded the case as peripheral T cell lymphoma. However, in flow cytometry, there was a question of clonality. So we searched the literature and found that there is a very good marker that can be utilized in flow cytometry assay and to establish the clonality. A newly discovered antibody that can distinguish normal peripheral blood T cells from malignant T cell clones is identified. That is TRBC1. TRBC1 phenotyping identified malignant T cell clones with 97% sensitivity and 91% specificity. So this is another study published recently in International Clinical Cytometry, and they also suggest that interpretation of those cytometric findings and T cell populations is very challenging. So they recommend the use of this anti-TRBC1 antibody, and hopefully this marker will be available in Pakistan, and we will start working on it to get the answer in such cases where clonality is questionable. However, if multidisciplinary approach is a practice in neurosciences and neuroscientists, then although we can still we were able to establish diagnosis, but if there are some cases where we cannot go for invasive procedures, where we cannot get a sample like excisional lymph node biopsy, and you have to rely on flow cytometry, then this marker is very useful. Still in T cell disorders, we are facing a lot of challenges to diagnose because we do not have T cell receptor gene rearrangement available in our country, and so hopefully this marker will be very useful if we start using it in our flow cytometry labs. So the experience acquired by all these cases is that difficult problem cases may need an integrated effort among different disciplines of pathology as well as radiology. And this united effort will help to improve patient care by correct diagnosis in timely manner, decreasing the number of repeat studies, like repeat testing sometimes, because if we do not get the answer, we repeat certain studies on different samples. And by this approach of integration, we can lower the overall cost that is usually spent on a diagnosis. So, to achieve a concept of one patient, one diagnosis, and one report, we can achieve it by a well integrated multidisciplinary teamwork, and therefore we will recommend the integrated approach, especially in hematology malignant cases. Thank you so much.
Thank you, Dr. Neela Mansoor. Very interesting cases and very challenging cases. As you know, the integrated approach, how integrated approach can help the patients and reach the accurate diagnosis and help for the, this. This is also for the better for the clinician to manage patients timely with the proper and the accurate diagnosis. uh, if you have any question and answer, until now we didn't receive any the question, so kindly you can write in the chat box. So now it's the time of the thanks. I would like to express my gratitude to all esteemed delegates of the session for their presence and the contributions to make this event great success. I extend my gratitude to our external speaker, that is Dr. Munira Bharani from NIBT, to take out time for her busy schedule to grace this event and shadow the very important topic of the our society, that is the coagulation disorders. And I also a special thanks to Dr. Sabha Jamal, which is the chair of the clinical laboratory of the Indus Hospital and the Blood Center, and the Dr. Fatima Meraj, which is the section head of the Hematology and the Blood Center, and all hematology faculty which make a full efforts to success this event. And at the last but not the least, I also are thankful for the icon team of the Indus Hospital, especially Dr. Kashif Shazli, for providing an immense support to make this hematology session which is more successful, and we can through this we can build emerging hematology insight to the future. uh, Thank you so much. Thank you so much for the all of the. Thank you so much.